Thank you, Dr. Ox, for that excellent talk and for taking us back down the memory lane to Dr. Wiscott and your associations. Appreciate that very much as always, and never tire of hearing that story from you. And next, once again, we need no introduction to Dr. Sangyan Pai, who is once again just, as I was sitting there, I was saying, what am I going to say? And I just wish that you could be in on meetings when she is there. Just her mind, the brilliance of her mind, her thought process, her incisive questions, and the time that she puts into the work for the Wiscott community. I cannot even speak adequately because they spend extra hours. This is not part of her work when she writes these Wiscott papers. It's part of what she does because of who she is. And I just want to say her training is from Boston. She worked in Boston Children's Hospital, and then now she has moved to the National Institutes of Health to be the director of the transplant program and gene therapy. And I do want to add that she is the person who brought gene therapy for Wiscott to the United States. She's spearheading gene therapy in the United States. She did gene therapy on 5 patients in Boston, and hopefully will continue the tradition and continue gene therapy. Without further ado, Dr. Sangyan Pai.
Oh gosh, I'm blushing, and also I can't say how much I admire and appreciate Dr. Iyengar, the WAS Foundation, everything that she has done. I've been enthusiastically recommending connection to Dr. Iyengar for every WAS family that I've met, and I think that she's done a world of good for the community. So I designed this talk knowing that there would be a range of people. I'm going to go over some material that is just meant to catch everybody up to the same stage, because I know there are many people here who know about transplants because they've already been through it with their children or themselves. These are the disclaimers. And what I plan to cover is some of the basics of allogeneic transplants, what people often call bone marrow transplant, but we can use things other than bone marrow, the historical and current outcomes of transplants, and then some basics of gene therapy and the outcomes of the gene therapy trials so far, as well as some future directions. So to start from the very beginning, what does the bone marrow do? The bone marrow is the factory that produces all of the 3 main blood cell types: red blood cells that carry oxygen, white blood cells of many different kinds that fight infection and regulate the immune system, and then the platelets that stop bleeding. And what are hematopoietic stem cells, or HSC, or sometimes we just call them stem cells? These are rare, special blood cells that live a long time, and each hematopoietic stem cell can either divide and make another stem cell, or divide into a cell that ultimately becomes one of these mature blood cells. And these are cells that produce blood for the whole life of the individual. So what is the problem in WAS? I don't have to tell you, and you've already heard from Dr. Ox. Pretty much every white blood cell, except for neutrophils, I would say, is affected and defective in function when you have severe forms of WAS. And we all know that the platelets are small and low in number and have a very short survival. So to fix this problem, you can't just fix the white blood cells or the platelets. You have to start from the beginning and replace the hematopoietic stem cells with healthy hematopoietic stem cells that will make normal immune cells and platelets. And we use currently chemotherapy for 2 reasons. One is we use some chemotherapy to kill the patient's stem cells, and the other is we use other agents, some of which are chemotherapy, to prevent the patient from rejecting the donor cells. And once we do that, then the donor HSC will come in and settle into the bone marrow and generate healthy blood cells. And our hope is that every patient would end up with 100% of the bone marrow replaced with donor cells. So what is it like to go through a transplant, or what are the stages? You start by identifying a donor and doing pre-transplant evaluation and treating all of the manifestations to be in as good shape as possible. You then go through an inpatient stay of about 6 weeks. We give the chemotherapy. I've often said it's like a garden. You apply the weed killer, you get rid of all the bad plants, you plant the seeds, and then there's about 3 or 4 weeks where the bone marrow is not functioning. It's sort of like the ground is bare. And then once you can see a little bit of bone marrow function, then the patient can be discharged. And then it takes about a year for you to have full reconstitution of the garden, so to speak. The outpatient follow-up starts out as weekly and then goes to about monthly. And the primary purpose of this when you're doing a transplant is to monitor for an important immunological complication called graft versus host disease. I told you that we have to do something before the transplant to keep the patient's immune system from rejecting the donor. Graft versus host disease is sort of the opposite. The donor immune cells can mistakenly think that the patient is an infection and try to attack it. And so we address this by giving temporary immunosuppression. And it means that for a period of time after the transplant, your immune system, which is the broken thing we're trying to fix, actually is made worse. Until that temporary period is over and the immune system becomes normal. And then afterwards, it's still important to have long-term follow-up. We recommend, certainly for the first, let's say, 5 years, to have at least an annual checkup. And this is mainly to monitor, to make sure the graft is still functioning, but also for the effects of the chemotherapy that we gave, because we currently still have to use pretty high doses of chemotherapy, and these can have impact on growth, fertility, they can cause hormone deficiencies, and unfortunately, even though it's a small absolute risk, it does cause an increased risk of certain types of cancers over the lifetime of the person compared to the healthy population. So what about transplant's history and the outcomes? The first 2 successful reports of transplant for Wiskott-Aldrich syndrome were using matched sibling donor bone marrow transplants in 1968 and 1978. And then this study in 1981 by Dr. Nina Kapoor and Dr. Richard O'Reilly reported 3 patients with Wiskott-Aldrich syndrome who all had matched sibling bone marrow transplant using a combination of 2 chemotherapy agents, busulfan and cyclophosphamide, and they demonstrated that the immune system was corrected because there were lymphocytes from the donor, and the platelets were corrected because they became normal in their number of platelets, and this established what became the standard way to transplant WAS patients for about 2 decades, which was to use busulfan and cyclophosphamide, so-called BU-Cy conditioning. Now, if you then gather all the results of many patients at many hospitals through the international registry, then you can report on what are the risk factors for who does well after transplant and who doesn't. And this was a seminal paper done by Dr. Lisa Filipovich, where she reported 170 patients transplanted over almost a 30-year period reported to the international registry. And she was the first to show that not only do recipients of a matched brother or sister do the best in survival, even the patients who got an unrelated donor transplant did quite well from a survival standpoint as long as they were young at the time of transplant. Whereas the patients who got a mismatched related, meaning usually a haploidentical or half-matched parent, they had worse survival. And then the worst survival was this small group of patients who had unrelated donor transplants and were greater than 5 years of age at the time of transplant. So she established that donor type and age at that time mattered a lot for survival. Well, the conditioning has definitely moved on from BU-Cy. I told you that busulfan is the agent that we use to kill the stem cells, and cyclophosphamide is the agent that we use to prevent rejection. But now there are a number of other agents, some of which have less toxicity than busulfan and cyclophosphamide, some of which are entirely different agents that don't even fall into the class of chemotherapy. So the question in the modern era is what factors are important for survival now? Which donors have better outcome? And are these newer regimens the same or better or worse than BU-Cy? So the Primary Immune Deficiency Treatment Consortium, which is a group of 40-plus institutions that have been gathering the results of transplant for WAS and other diseases, published this paper of 129 patients with WAS who were transplanted in the modern era between 2005 and 2015. And there were some characteristics of this cohort that really gave us more insight beyond what had been reported in the past. First, this is the distribution of the donors that were in that study, and you can see in the purple that there was quite a number, pink, I guess it's pink, there were quite a number of patients who had had umbilical cord blood transplants. So that allowed us to see how do those patients do compared to the other types of donors. Additionally, this is the conditioning regimens, and while more than 50% of them still got the classic old BuSci. There are a number of patients who receive busulfan with fludarabine. Oh, I guess the arrow doesn't show up here. Busulfan and fludarabine, and then some who receive fludarabine and melphalan. So we had the opportunity to compare those patients. So first, in terms of survival, the survival of patients getting an unrelated donor or other transplant at greater than 5 years has definitely improved from the old, but we still see a difference. Now, I didn't put a slide on this, but these are really largely pretty much all children. Whereas the European group, Michael Albert, has published pretty recently outcomes of transplant for a number of different immunodeficiencies in adults, including WAS. And they actually do pretty well and probably do better than this 66%. So I just want to place that caveat in there. Then when you look at donor type, the red line at the top is matched sibling donor, which in this cohort was 100% survival. But you can see that the other donor types, matched unrelated donor, mismatched unrelated donor, and importantly, the cord bloods are all overlapping. So if you have a patient with WAS and they don't have a matched sibling, I think you need not despair, when it comes to survival. And you can choose pretty much among any of those sources, and they'll probably have a similar outcome in terms of survival. And the same is true if you divide it according to bone marrow versus peripheral blood versus umbilical cord blood. So I think that's good news. Oh, and the other caveat to say is that there were very few haploidentical transplants in this cohort. So we really can't say how do those transplants compare. The other is that in the European studies, they have many more patients with haploidentical or parent donors, and those patients appear to be doing pretty well. So I think even now we can start to say that with more experience accumulating, we can probably make haploidentical transplants have as good survival as these other donor types. Backwards. Okay, there we go. So what about beyond survival? What about chimerism? So chimerism is the word that we use to say what is the mixture of donor cells versus patient cells after a transplant. Because our goal, of course, and the reason why we tend to give pretty high-dose chemotherapy is we want to wipe out all of the stem cells and replace them all with the donor cells. We call that 100% donor chimerism. But for reasons that we don't understand, some people don't come out 100% donor chimerism. And we suspected from other studies that some cells may be easier to correct to fully donor than others. And this is pretty much what we saw in the PIDTC study. I'm going to go over this relatively quickly because there's a lot of detail, but for each of these rows, the first row is T-cell chimerism, the second row is B-cell chimerism, and the last row is myeloid cell or other white blood cell chimerism. And everything that's orange is the percentage of patients who have greater than 95%, so practically full donor chimerism. And you can see that in the day 100, there are a number of people who have colors other than orange, meaning that there are people with mixed chimerism at these early stages, and that the first bar, which is reduced intensity conditioning, those patients seem to have more mixed chimerism than if you give higher dose chemotherapy. When you go all the way to the right in year 2, you can see that the T cells and the B cells, practically all of the patients have full donor chimerism, and this is because the T cells and the B cells tend to become donor over time. Whereas in the bottom row, at the very last columns, there's some patients who are in red, and that means they have less than 50% donor chimerism in those myeloid cells. And we also showed that it appears that busulfan-containing regimens work better for getting full donor chimerism than if you don't use busulfan. Why does this matter? This matters because those same patients who have less than 50% myeloid donor chimerism tend to have low platelets. So the third bar in each of these panels for 1 year, 2 years, and 3 to 5 years post-transplant are the patients who have low mixed chimerism, less than 50%, and they have lower platelet counts. So whatever we do in the future to improve transplant, what we really want is to have consistently high donor chimerism in all compartments so that the platelets will also be corrected. The Europeans took another approach. They did a retrospective study in their registry of 197 WASP patients, transplanted at a similar time frame, 2006 to 2017, but they specifically were comparing the patients who got busulfan and fludarabine to the ones who got treosulfan and fludarabine. Treosulfan is a chemotherapy agent which is a little similar to busulfan, but less toxic. It's FDA approved in Europe, so a lot of patients have been receiving transplants using that. And when they compared them, they found that the survival was the same. But when you look at graft failure in the blue on the left side, the TrioFlu patients had more graft failure. If you look in the middle panel and the third panel, and look at the percentage of patients who needed a second transplant or a stem cell boost or a donor lymphocyte infusion or got splenectomy, the TrioFlu patients had many more second procedures. And then they did a similar chimerism analysis to what we did. Here, greater than 95% donor is the dark green, and the TrioFlu patients had more mixed chimerism. So again, these are both studies saying that for now, busulfan seems to be associated with the best outcome. Now, what about gene therapy? So I told you that allogeneic transplant is when we identify a donor, we get cells from them using bone marrow, peripheral blood, or cord blood, and use that for the transplant. With gene therapy, we're using the patient's own cells. So you can get bone marrow or mobilized peripheral blood from the patient instead of from a donor. You can genetically modify them outside of the body and then give that back as the transplant. I'm going to go to the side here a little bit and give a little bit of a primer on genetics and genes and mutations. So I like to do this as a cooking analogy. Genes are like a set of instructions for how to make the proteins that make a cell work. And the genome is the word that we use for all of the DNA in a person's cell. It's sort of like a massive recipe book, like Mark Bittman's How to Cook Everything. And a gene is a segment of DNA that encodes a particular protein. In the case of WASP, it encodes WASP protein. It's like a page in the recipe book. It could be like how to make a hamburger. And then the promoter is the part of the DNA that tells the protein when it should be made, in which cells it should be made, at what time it should be made. It's sort of like the intro to the recipe saying, you should make the hamburgers for a 4th of July cookout. And it may not be appreciated for Thanksgiving dinner. And then amino acids are the building blocks of the proteins. It's like the ingredients in the recipe. And then the protein is the hamburger. Now, there are lots of different types of mutations, which are mistakes in the DNA, and some of them are worse than others. So we call it a nonsense mutation if there's a mistake in the recipe book such that it just stops. You don't even get the whole ingredient list. And there can be mutations that are deletions, where let's say the beef patty is missing, so that clearly is not a hamburger. And then there are some that are so-called missense, meaning that there's an ingredient, in every part of the list, but the ingredient is so wrong that it's really not functional. So it's really not even pretending to be a hamburger. And then there are missense mutations where the substitution is something that isn't that bad. You can kind of get by, and some people may not notice the difference between the chicken and the beef patty, but it's still not a hamburger. And I like to think of these first 3 categories as more like the classic WASP, or what is in this new paper from Dr. Albert and Dr. Ox, the class 2 mutations. And these missense partial function mutations as the class 1 are sort of more like what was described as XLT mutations. Now, how does gene therapy work? Gene therapy uses, when you're using a viral vector to add a copy of the gene into the cell, are custom designed viruses. And it's sort of like a delivery truck that brings a normal copy of the gene into the cell. And you can see that there's this black X where the WASP gene is, and it's broken. And then you bring in this copy of the WASP gene that is normal, and it inserts itself somewhere into the DNA of that cell. So if you get the copy of the gene into the long-term HSC, all of the blood cells coming from that cell will carry the gene. Now, when you do this, you deliver the gene to some cells and not others. And some cells may get 1 copy, some may get 2, and some may get none. So this is sort of like, and it also inserts into a different place in each cell. So this is not gene editing. This is not going in there and fixing the gene that's broken. This is adding a a page with the correct recipe somewhere in the recipe book, but it's probably going to be out of order. And as long as you can find it, it's okay, but it's not the same as fixing the gene itself. And one copy may or may not be enough. So we already heard that it was a tragic outcome of the initial gene therapy trial conducted by Christoph Klein in Hanover, using this, what we would now consider an old-fashioned and unsafe gamma retroviral vector because the vector caused leukemias. But since that time, the entire field has moved to lentiviral vectors. And lentiviral vectors have a very different property in terms of how they insert, and they appear to be much, 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 much safer. So the trials that were conducted for WAS were conducted in Milan, London and Paris, and in Boston. We all used the same vector, which is a lentiviral vector that carries the human WAS gene, and it has its own promoter, which is the same as the human WAS promoter, so that it would hopefully do the expression, have the instructions just like in normal cells. And we all used busulfan and fludarabine conditioning. The Milan group used also 1 dose of rituximab, or anti-CD20 antibody, to get rid of those autoreactive autoimmune B cells. And then we all used this same vector to transduce stem cells. I'll tell you in summary that similar to transplant, we all saw quite uniform correction of the immune system. People improved in their eczema, their infections, they came off of immunoglobulin, their B cells could work, but the outcome in terms of platelet reconstitution was really variable. And I'll show you, some of the reasons why that might be. Unfortunately, with 40+ patients receiving this vector, there has been no leukemia seen with this vector to date. So when I was in Boston, we ran a trial for Wiskott-Aldrich syndrome using this vector. We enrolled 5 patients. They were all children, and we had 5 to almost 9 years of follow-up at the time that we published late last year. And some of the key findings is that we did succeed in transducing the stem cells. All the patients had the gene carried in all of their blood cells. We saw great correction of T cells, eczema, infection, B cell function. They all came off of immunoglobulin. The 2 things, one of which I'll get into more than the other, is that we had 2 patients who had autoimmunity going into gene therapy who then had flares of autoimmunity afterwards. And this was a little bit different than what was seen in the Milan trial, for example. And we believe this is because the immune cells that regulate autoimmunity, regulatory T cells and IL-10 producing regulatory B cells, took a long time to recover. And that during that kind of vulnerable period where the immune system was not well regulated, that's when the autoimmunity flared. And then the other problem is that the platelet defect was only corrected, oh my gosh. Why is it that your teenage young adult sons never call you? And then they call you right at the wrong time. We'll talk to him later. I'm sure it's fine. If he calls again, maybe I might have to answer. I'm sorry. Okay, but the platelet defect, as I'm going to show you in the next couple slides, was only corrected in the patients who had more than 2 copies in the stem cells, because it appears that 1 copy is not enough. So we did see that the mean platelet volume went from smaller to bigger in every patient, but we saw 2 different kinds of patients. There were 3 patients who had very low platelet counts after gene therapy, around 50,000 or below, and 2 patients who were greater than 100,000 consistently. And this was very closely correlated with how much gene we saw in the white blood cells. This is sort of like the myeloid donor chimerism in the transplant situation. And just to break it down for you a little bit, the top 2 patients, the purple and the blue, had vector copy numbers of about 1 copy per cell. But the 3 below that, it was 0.2 or 0.3. So that means that not all their cells carried the gene. It was probably only about 20 or 30%, and they only carried 1 copy. What we think is happening is that And at that time, when we did this trial, we would transduce the cells with the vector and then give them chemotherapy at the same time, and then give the gene therapy cells and find out what the vector copy number was later, because we weren't freezing the cells at the time. And when we looked back, we saw that those same two patients who had really great platelet reconstitution had more than 2 copies of the vector in their cells, whereas the other patients had more like 1 copy. So it appears that when you have 1 copy per HSC, that only leads to a portion of the white blood cells carrying the gene, and then you end up with a low platelet count. Whereas if you have 2 copies per stem cell, then more of the white blood cells have also 2 copies, and then you have a good platelet count. So what is the future? We need a vector that makes more WAS protein per copy, and that hopefully drives better platelet production. Maybe there's some stage in the platelet precursors that needs more WAS protein, and we need to make that level higher so that the platelets will develop better. And there are 2 trials that are in development. One is in Seattle. The PI is Dr. David Rawlings, and he is going to be using a vector with a stronger viral promoter instead of with the human WAS promoter, with the idea that it should drive higher expression in every cell. And then the trial that we are planning to open sometime at NIH in partnership with a company called Immunovec is a vector that we hope will work better in platelets and also drive higher levels of platelet WAS protein expression. So this is a lentiviral vector, very similar to the previous clinical vector. It has a small WAS promoter, but then it has these 2 additional pieces of DNA that are active in making WAS protein expressed in the platelet precursors. Also, the part of the vector that encodes the WASP gene has been modified in order to make more protein per copy, so that even maybe 1 copy would be sufficient, but this is something that we would actually test in the trial. So our plan is to open a trial that has 6 patients enrolled. We would enroll patients 3 years of age and up, all the way to age 60. And then they have to not have a matched sibling donor, they have to have thrombocytopenia, and they have to have adequate organ function. And the first 3 participants, we would enroll the so-called classic WAS with class 2 mutations. And if we see that all 3 of those patients have good platelet reconstitution, then we would open up the trial to include the patients with class 1 mutations, because we wouldn't want to go forward with them without having some idea that this vector really is working for platelet reconstitution. And then we were also doing a few things that are improving upon the old trial. We will do the gene therapy in the cells and then freeze them so that we can check and make sure that the vector copy number is good enough, and then bring the patient back for the chemotherapy and the infusion. We will give a single dose of rituximab, just like the Milan group did, to try to get rid of any autoimmunity and maybe prevent flares after gene therapy. And then we will use busulfan because it does appear to be best for transplant, but we're going to have a lower target than we did in the other trial, which was all children, because we suspect that there may be older adults who will want to enroll. So this is my last slide. This is just a little bit of a score sheet of transplant versus gene therapy, compare and contrast with some notes. So transplant, you do need a donor, but I think that the news is good in terms of the outcomes of using so-called alternative donors, cord blood, haplo. It means that all patients really do have a potential donor. Still, it's very clear that transplant has risk of graft versus host disease and gene therapy does not. They both can achieve immune correction. They both have variability when it comes to platelet correction. Both of them can have autoimmunity recur after treatment, although the reasons why and the risk factors may be different. I put 3 checks for the chemo side effects for transplant and 2 for gene therapy, because in general we can get away with less chemotherapy and gene therapy, but busulfan is still best, and so we're still kind of facing the same risks. And what we really need is non-toxic chemotherapy, or non-toxic conditioning, something that can get rid of the HSC without using chemotherapy and that doesn't have the toxicity. And that would be an absolute game changer for both transplant and gene therapy. are so-called XLT patients suitable? I think if we get to the point where we see consistent correction, especially of platelets, and if we combine that with non-toxic conditioning, then pretty much everyone could be suitable because the risks would be much less. And then finally, we're happy to say that we haven't seen any insertional leukemia to date. And with that, I'm happy to take questions.
Thank you so much, Dr. Ox, for your history and all of the work that you've done for the WASP community over many, many years. And thank you, Dr. Pai, for the future of what's to come and for all of your hard work as well. And thank you, Dr. Iyengar, for the foundation work and putting this group together. Now, these are some resources for the IDF. If you have a question that was not addressed in this session and you don't get to bring up during Q&A, or perhaps you think about it after the Q&A, please visit primaryimmune.org/askidf, and a member of our team will connect with you to answer your question or direct you towards an appropriate resource. If you're looking to connect with others within the PI community, IDF offers virtual Get Connected groups where individuals with PI and their families have the opportunity to connect, share experiences, and receive support in their local communities. And finally, please remember to complete your session survey through the conference app. Also, I'm sure that you can come visit Dr. Iyengar to get involved with the WASP Foundation as well. We now have some time available for Q&A. If you have a question, I saw some hands already, I'll bring the mic to you.
Hi, I have a question about the alpha-beta T-cell depletion. Can you explain a little bit about it, and why don't you use it also in match-unrelated donor, and only in haploidentical?
Yeah. I'm going to answer that along with some unasked questions that you have. So as you know, with a haploidentical transplant, you have to do something in addition to what we usually do in a matched unrelated donor transplant to prevent graft versus host disease. And there are two different general methods. One is to remove the T cells from the graft, and that's the TCR alpha beta depletion is the most modern way to do it now. And the other is to do post-transplant cyclophosphamide. Is that like humming? I don't know. Okay. I'm trying to turn this one off. Maybe we just use one. Is that better? Okay, it's a little better. All right, so, and then the other method is giving an agent such as cyclophosphamide, which kills T cells after the transplant, and leaving all the cells, the T cells, in the graft. So both of these methods are becoming increasingly used. It's hard to say whether one is better than the other. It's pretty much according to what each institution is comfortable with. At the NIH, we're using a lot of post-transplant cyclophosphamide. The reason, there isn't really a good reason. I would say that it's more of a historical situation why TCR alpha beta depletion isn't used more often in unrelated donor transplants. It really could be. And, there are definitely, I don't know what to do. I really want to turn this off. I think turning this off would be the best. No, I don't want to do that.
Use this, and I silence.
So there are pluses and minuses. When you take the T cells out of the graft, you do increase the risk of graft rejection. Another thing is when you take the T cells out of the graft, you don't have to give any post-transplant immunosuppression. You don't have to give cyclosporin or tacrolimus or anything, but you have very, very few T cells. And so the risk of viral infection is generally higher. So there isn't a good reason. I would say that, because it was developed specifically for haploidentical transplant, people tend to stick with it. for haploidentical. But I have a different study, which is for SCID transplant, and there we're using T-cell alpha beta depletion for both haploidentical donors and for unrelated donors. Well, the GVH risk is definitely higher in older people, both older children and in adults. I wouldn't say that there's a relationship between what kind of GVH prophylaxis you use and the age. It's just that the risk is higher. I'm thinking about the older patients, the age should do alpha beta. Yeah. In that population, maybe. Yeah. Well, I do think that in the North American community, it would be great to accumulate more experience doing haploidentical transplants for WAS. And it could be done either with T-cell alpha beta depletion or post-transplant Psi, and then it would be great to gather a whole lot of them and then compare.
Just one. Yeah, okay. So I was asked by a Russian colleague, he said, why in the United States don't you do post-transplant cyclophosphamide in every patient? And that's what they do in Moscow. And they claim it's excellent. And of course, the machinery you need to deplete T cells doesn't always work. And you need special reagents, and they don't get it in Russia anymore. So they just do their transplants with everyone with post-transplant depletion of T cells with cyclophosphamide. And I had no answer. I just said, well, maybe we are stupid.
No.
Isn't that more toxic?
Yeah.
Than other agents?
Yeah, so the reason why, before I moved to the NIH, where we were really focused on post-transplant Psi, I tended to avoid it because, yes, there are a lot of advantages. It's cheaper. It doesn't require any special machinery. But I've been spending a lot of my career trying to reduce chemotherapy exposure to the patients, and now you're like giving some more back. So I don't love it for that reason. I think when it comes to the malignancy transplant setting, it's been a game changer throughout the world, to be able to do post-transplant Psi, and it's very effective. So I do think it's a trade-off between the risks to the patient and the simplicity of the approach.
Well, and you do, and then I should do a lot of post-transplant cyclophosphamide, right? In Seattle also, we don't do the depletion because it's a headache with this machinery, and so it's a trade-off. But I think that compared with the old transplants we did in the 20, 30 years ago, when we yearly used large amount of cyclophosphamide, they all got cystitis and terrible. That little bit after transplantation is really minute compared with.
It also means that if you want to do alpha beta T cell depletion, you have to go to an institute that is really doing that.
Yeah, it's
normal cases that have experience.
Yeah, it's expensive.
I don't know that most people in the room know what alpha beta T cell depletion is. So could you please go back a step further and say what is GVHD, the alpha beta, and then thank you.
Sure. So, we say we're doing a stem cell transplant, but I know I promise, I see you. We'll get to you in a second. Yeah. So we say we're doing a stem cell transplant, but really it's only about like 1% or 5% max of the bone marrow, let's say, that contains stem cells. There's about 5 to 10% of the marrow and many more for peripheral blood that is mature T cells. And those T cells from the donor are what causes graft versus host disease, because those are the cells that go into the patient's body and say, hey, I'm not in my home, and this is a foreign environment, and maybe some of these things are infections that I need to kill. So that is why one approach to preventing graft versus host disease, especially in this setting where the cells are only half matched, so they're really, really prone to causing graft versus host disease, is to remove the T cells from the graft. And 90% or so of the T cells are so-called alpha beta T cell receptor positive T cells. So T cell alpha beta depletion means removing those alpha beta T cells.
So I have a question in regards to fertility. I guess to give you a little background, I had classic, and I was diagnosed in '97. I had my splenectomy and a bone marrow transplant from my older brother. I was fully 100% after 10 years old. I don't have any issues with it anymore. But I did have the busulfan and Cytoxan. And I've gotten conflicting answers throughout my whole entire life in regards to it because I do want to have children eventually. So I was wondering your, I guess, opinion on what you think my chances of fertility would be, or should I just bite the bullet and get tested? Because I'm honestly kind of scared to. So I don't know, I kind of want to get both of your opinions in regards to that and what you think would be my best option, or if you think that I could, if you think that I couldn't, so on and so forth.
Do you want me to answer that question?
Why don't you start and I will follow?
So thank you for that question. It's a very important one, and it's one of the reasons why I'm happy that in general we've been moving away from Bu-Cy to Bu-Flu, because my hope is that this will be preserving fertility for more people. You know, I don't think there's a single answer to your question. I think the advantages to getting tested would be that you would just know, you know, whether you have no sperm production, whether you have few sperm, or whether you have normal sperm count. The impact, if you did have it from the busulfan and Cytoxan, would be on the number of sperm that you have. The other fortunate thing is that these days, if you get tested and then you know what your status is, if you need assistance, you know, for having kids, you know, they can take a single sperm and like inject it into an egg. And so, you know, the technology has advanced a great deal. And so that would be my argument for getting tested. The other is you could just go ahead, and if things aren't happening, then you can get tested. And in terms of, you know, why you're getting conflicting reports, I think it's because it's not 100%. And in particular, one of the things that may have impacted how much of the people in your age group have infertility or not is that back then we weren't always measuring the busulfan and making sure that everybody was getting the amount of busulfan that we wanted. So some people may have gotten more than they needed, some people may have gotten less than they needed, and then that could have a different effect, besides the fact that every person's different.
So I think the Viscount Aldrich Foundation should look into this. You have the means to figure it out. I know probably about 6, 7, even more who are at an age where they should have children, and none of them has children. Now, I don't know if it was voluntarily or if it was biologically, but that is a real issue, and I think it needs to be addressed. Now, for patients who have the mild form, you know, there is time. You could wait until they are mature, and you can collect the sperms before they get gene therapy or before they get a marrow transplant. So these are all things which we need to consider, and it's usually just put under the carpet, the fertility issue. But it's a very important point, and there are no data. But the IDF, you as part of the IDF, you could initiate a study for worldwide. Okay.
So, Dr. Pai, I have a question for you. Yeah, your last chart, the very bottom, you said something about for XLT you had a question mark, and then you said, we need more efficacy. Can you say more? What are your criteria for more efficacy?
I mean, mainly what I mean is that I would hate at the current stage, particularly for transplant, you know, where there's risk of graft versus host disease, where we're still using pretty high dose chemotherapy, I would hate to be rolling the dice when it comes to how good the platelet reconstitution is. And because the platelet reconstitution is so variable, it's not that I would say no to transplanting a so-called XLT patient. It's more that I would feel more comfortable freely offering it and encouraging people to go for it if the platelet reconstitution were more consistent. If I felt like with, the vast majority of patients were achieving a good platelet outcome. Yes, yes. I mean, I would say that for gene therapy too. I mean, I would say I have hope that either or both of the new vectors that will be tested in trial in the future will be more consistent. Then it's even better, because then you're not subjecting people to the graft versus host disease risk.
What's the threshold? What's the definition of this?
Oh, I don't know. I mean, better than now. I would like it to be a rare thing that the platelets don't recover. I'd like it to be as consistent as the immune system correction. I mean, greater than 90%, let's say. Something where it's a rare occurrence instead of pretty common.
Hi. My question is, I have my 21-year-old, and at the age of 16 months, because we could not keep the platelets high enough back then, of course, they told us to get his spleen removed. So we had his spleen removed because he was getting platelet transfusions like weekly. And I heard you say that, platelet transfusions really don't help. Back then, we didn't know that. We were listening to the doctors. Well, when he got in middle school, his platelet count started to drop again, and drop and drop. Well, come to find out, the spleen had grown back. And I'm just trying to figure out, since we know it can happen, because it has happened, if that happened because he was at such a young age when we had it removed, or, were there cells left or something, and is it possible for that to happen again? And if it is, because we're hoping that, as time goes on, there's some type of treatment for him, should we leave it alone instead of, having it removed again, because the platelets start to drop again, and they're going to want to start doing platelet transfusions again?
So clarify this. He has had a hematopoietic stem cell transplantation? No.
He's untreated.
So he's untreated. No, there is a component to the low platelets that is actually autoimmune. That would be an ITP, and I have seen this in patients, and you can test it. If, for instance, if you would get a platelet transfusion and they don't go up, that means they are being destroyed. And that's a difficult situation. And we suspect, and we have some experience with it, that frequent platelet transfusions can actually sensitize. And so they become on top of the problem with platelets associated with Viscot or XLT, they actually get the ITP, so they have two problems. And in this case, they would have to look. There are some labs that look for autoantibodies against platelets. If he has it, he could be treated with a standard treatment, rituximab, to eliminate the B cells that produce these autoantibodies. But that has to be first demonstrated, that he actually has low platelets because of these autoimmune phenomenon. And if he gets platelet transfusion, that is a very easy test. You just measure if there is any increase, and the platelets should stay up for 3-4 days. But if they drop down right away, then that is a destruction from what he has in his blood, these autoantibodies.
Dr. Otts, let's pretend that we know that it's not ITP. Can leave it on. Let's pretend that we know it's not ITP, that it's because his spleen grew back. What do you think they should do? Should they have another splenectomy or not?
Well, first you would have to demonstrate that the spleen has gone up. And there is a simple test which I learned in medical school, that is holly jolly bodies. And so you just look, the hematologists know how to look for it, and if he has these holly jolly bodies, then he has no spleen. There is a more modern test. You use radioactive red cells and put them in, and you see that they show up in the liver or in the spleen, and then you know that there is a spleen again. But if you go to the experts, you find out.
But you already know that his spleen is back. They already know that the spleen grew back.
How do you know?
No, but they could, was it visible on ultrasound?
Red blood cells, and they disappeared. You know, I am not in favor of splenectomy, although it's a very effective way to deal with these low platelet counts. But the long term, you take antibiotics, you know, and that is so crucial that this is being maintained. So you know, you have a choice here, and it's really up to you. You are over 18, right? So you make the decision. You get the pro and the contra to the splenectomy, and if you think it's worthwhile, it's not a big surgery. You know, they just take it out. So that would be one way. On the other hand, how low are your platelets? 80? So just don't play rugby. Play soccer instead. You know, you get bloody feet, but you don't get. You have to protect your head. But 80,000 is not bad. And in some gene therapy patients, that's what you get. So I would not worry about it until they really drop down. And if your spleen bothers you, take it out. If your right eye bothers you, take it out. It's in the Bible. Very interesting. I have never heard in a patient who had been splenectomized with XLT who grew back a spleen. Yeah.
But it's common with ITP patients. I read the paper saying that in some patients it's growing again. Yeah. Also, there is the British test that actually trying to figure out in advance if it's good to be splenectomized, because also your liver can disrupt some of the platelets. Yeah. And there is a test that uses X-ray. I don't remember the name of that. That actually predict what are the chances that the splenectomy will be beneficial.
Yeah. Okay.
This is in regards to a young baby who hasn't had a transplant. I've heard that, I keep hearing, so let me back up. When my son was born 20 years ago, we were told not to do the platelet transfusions and don't do IVIG in order for the transplant to be more successful. But I'm hearing now that the push for IVIG, and I'm wondering, is that something new that before transplant? Is that something new that's encouraged?
No. So I have never heard not to use IVIG because that would interfere with either transplantation of hematopoietic stem cells or gene therapy. That's a myth. But platelet transfusions, that can sensitize. And early in Seattle, when Don Thomas did transplant, if the patient had frequent transfusions of blood or platelets, they actually didn't do them because they were so worried about the rejection of the grafts. But no, we have better medicine, so you can do some platelet transfusions if it's really necessary, but just to do it routinely is still a no-no. Do you have any ideas?
I would agree. I don't think there's any reason why not to do IVIG from a transplant risk standpoint.
So I have to quote Dr. Kohn, not this one, but the one who did the first fractionation, and he had on top of his disc, he had a quote from Faust. He said, "Blood is a very special juice. Blut ist ein ganz besonderer Saft." So blood is, that's where the gamma globulin comes from. And Kohn actually was the first one who isolated the different proteins. And one of them, fraction 2, was the gamma globulin, a very special juice.
Okay. Hi. So Dr. Albert recently published a paper on XLT, as I'm sure you both know.
With Dr. Ox.
And I am curious to know, I guess Dr. Pai and Dr. Ox, has your opinion changed now and your advice to XLT patients going to differ? I know on a lot of the slides we're still referring to XLT. So as a mom of an XLT boy, I'm wondering.
That's a very important question. And you will see here 2 patients with what I call XLT. One is 83, and the other one I think is 29 from Israel. And the gentleman from Israel has an uncle who is 59. So some of those XLT patients do quite well. But overall, I showed the slide where the event-free, there are quite a few roadblocks. And so if either gene therapy or hematopoietic stem cell transplantation becomes so easy to perform and successful, then I would say go for it. Go for it if you have any type of mutation in the Viscot gene. Even if you have intermittent thrombocytopenia maybe, because you could die from a bleed. But it's all a question of how do you weigh the advantage and the disadvantage of such a procedure? But originally, we would not transplant XLTs. But now I think I'm much more in favor of it.
Yeah. So first, I just want to point out that I use the term XLT as little as possible in my presentation and put quotes around it because I'm really trying to wean myself and the entire community off of this term. I very much agree with Dr. Albert and Dr. Ox's paper that we should be talking about WAS as a spectrum. And, to the extent that we distinguish between one group of WAS patients and another, I think it should be according to those mutations. Now, the question of whether it's that particular set of data has changed my mind, I think it has changed my mind because it has given some more nuance to what it is that WAS patients with class 1 mutations are likely to experience. And I think that paper was important to show 2 things. One is that the event-free survival is clearly worse than patients who don't have any WAS. But more importantly, if you look into that paper very closely, the event-free survival was survival without, any of the different bad things that can happen in WAS: severe bleeding, severe infection, malignancy, autoimmunity. But when you split them out and then you look at individual outcomes, in every case except for malignancy, bleeding, autoimmunity, and bad infections, those were still at a lower rate in the patients with milder mutations. But the risk of malignancy was actually the same. And so I think that this is one argument in select cases to proceed with transplant for so-called XLT patients. But it's exactly as Dr. Ox said. This is currently at the level of a personal decision, weighing the risks and benefits for your particular situation. And you have to kind of make these decisions with your gut. When the person is old enough, the patient is old enough to participate in his own decision-making, that's one aspect. If it's a child, it affects the whole family. the whole family goes through something, and you're looking at what is our family and the individual person going to go through with one path or another, and you can only choose one path. I always like to, reassure people that I'm not going to tell you, especially in this quote XLT situation, I'm not going to tell you you're doing the wrong thing by not choosing the transplant, and I'm not going to tell you you're doing the wrong thing by walking away from the transplant, because it's an individual personal decision. And I can give the same information to, two families. One family will hear what I had to say and run away screaming, and the other, family will say, well, I hear all you're saying, but I want to take those risks rather than stay the way things are. And there's no right or wrong. So that's where I think the quote XLT is. In fact, Dr. Albert and Dr. Valet and I are going to apply to Blood and ask them to let us write one of those How I Treat articles, and we're going to argue in there using some of the data from this paper to say we need to, I have a folder in my email called No More XLT, because we're going to stop using this term and think about the disease in a different way. Yeah.
And in the UK, they have the program of memories,
Yes.
and that actually take care of.
Yes.
But what do you do in the US, for example?
Yeah.
I know it's a problem also in Israel, because they are not taking care just occasionally by some doctors.
So you're talking about the care of adults, and are you talking about transplant for adults?
No, well, it's the same, because
Yeah.
somebody has to take care of it.
Yeah, yeah. Well, I will say for NIH, you know that Dr. Luigi Norangelo has had lifelong almost interest in WAS. He is very interested in seeing such patients and studying, all the different manifestations in older WAS patients. So he would be happy, I think, to enroll on his research study and give some clinical advice. At NIH, we don't transplant children under 3 years of age, but it's quite standard for us to transplant adults with immunodeficiency. It's kind of bread and butter for their service. So, we are open to doing that. One of the difficulties is, sometimes a patient will refer themselves to me, an adult with whatever disease. It's very hard to find a transplant center locally, that feel comfortable to take them. So I think that's still a major problem, in addition to, not having enough internal medicine, physicians who are expert. A lot of children's hospitals will go up to 30, maybe even 35, but then after that, it's like, no way.
Well, in Seattle, we take care of, my oldest patient is 73, not a Viscott, he's an XLA. But if they have to be admitted to a hospital, then they have to go to the adult. But we have some good they trained with us, they're internists. So in Seattle, it's not a problem, but in most places, it's really a problem to take for. But should we now transplant all the XLTs or mild Viscotts? You can see the progress, and I think the transplant right now in the PIDTC, the survival is over 90% in younger patients. So, and gene therapy comes online. So if you are a pessimist, then you go for transplant and just want to get rid of it. If you're an optimist, you say, okay, I will make it until all these methods and therapies are perfect. And then when I'm 25 or 30, I get my gene therapy or something like this. So again, you know what we both said, it's a personal decision.
And the other thing is I don't know how many of you went to Dr. Cohn's gene therapy talk this morning. I mean, there are many, many people who are working very hard on being able to do gene therapy without taking the cells out and just injecting the vector and having the vector go to the stem cells in the marrow and fix it. I mean, when we're able to do that, then there will be so little risk involved. So I agree. I think it depends on how long a person is willing to wait, how long they think their body will let them wait. It's, you know, because see, there's no crystal ball. It's really, you know, a decision you make with your own life, you know.
I have just one more question. So I'm one of the rare few where my mother was not a carrier at all. I also have two older brothers that weren't affected and a younger sister who's not affected at all. I was just kind of wondering, from your experience, are you seeing more cases where their mother is not a carrier and someone is affected? Or what do you think in my situation, how I became, I guess, diagnosed with it?
Well, that is called a de novo mutation. And in some diseases, it's more frequent than in others, but there were some ingenious geneticists from England who almost 100 years ago predicted that lethal X-linked diseases have 30% of de novo mutations. Otherwise, the disease would disappear, right? Because in the old days, the affected males all died. They had never offspring. So in order to maintain the disease at the level we see, you have to have 30% new mutations. Every generation has 30%. So usually in a standard family, if you go back three generations, there probably was a gene not mutated. So that is a very natural way that there is a mistake, usually in a spermatogonia, because, you know, they have much more divisions where something can go wrong than the 400 eggs which a woman produces. And there are some diseases where almost every one is a de novo mutation. So there are diseases which have we call a gain of function mutation, a dominant gain of function. And there we can actually show that it comes from one spermatogonia. And so if the man gets older, 10%, then 20%, then 30% of the sperms have that mutation. But Viscott is not one of those. It's a very interesting, and the British call it permissive spermatogonia problem.
We have another question here, and then I'll pop up front.
Hi. So we recently found out I'm a carrier, and then my fiance had Viscott as a baby and was transplanted. So we have a lot of questions about kind of what that would look like if we had a girl, if there's ever been a girl with two X's mutated, how that would present, etc.
Well, that's an interesting experiment of nature.
Yeah.
So if there is a boy, the boy has the X chromosome, which is normal, but has 50% chance from you to get the abnormal. So in your case, there would be 50% of the boys would be affected.
Right.
But if you would not be a carrier, all the boys would be perfectly normal.
Right.
Now, in terms of the girls, you have a chance of 50% to get an affected girl which has Viscott-Aldrich syndrome.
Yeah.
So you are on a hot spot.
Yeah.
I'm his mother, and so I will
Yeah, yeah.
So because the mutations that she carries is different than the mutation that Tate has, could the girl then have 2 different mutations of
Yep.
Wiskott?
Yep.
And is that even?
2 X chromosomes that each one would have its own mutation.
Would still have disease.
Yeah, and will have the
Yeah, it would
disease,
definitely
yes.
have Wiskott, but is that
Yeah.
even possible for life? I mean, would it be just so severe that the baby wouldn't even survive? No. You don't think
It
so?
would be like a boy with Wiskott.
Yeah, but you would have like a double dose of Wiskott. No. No, you don't think so?
It would just be no protein, like in the boy, he has no protein because his only X chromosome has a problem, and there would be no protein because both of the X chromosomes in the girl will have the problem.
It doesn't matter whether you're missing 1 beef patty or 2 beef patties. If you have no beef patties, you have WAS. So it's not like a double dose of badness. It's just not having the beef patty.
Yeah, you cannot go in the minus. You just get to 0.
And then my family, well, my nephew has Wiskott. That's how we found out I'm a carrier. And he had he has 0 Wiskott protein, so he had the classic version, but his just presented a lot more mild than Tate's. Do you think that if a girl had both, her X inactivation would just kind of flip a coin,
Could be in between.
Okay, it could be in between.
Yeah. But I think you have to consider seriously in vitro fertilization.
Yeah.
And because this is a very high risk what you have
Right.
here. Yeah.
But if we were to do in vitro fertilization, would we still have the same chance of having every embryo we get have Wiskott?
No, you would have half of the embryos would be normal.
Okay.
50% of the boys would have it, and
Right.
and half of the girls would be affected.
Right.
So there would be some girls that would not be affected.
Okay.
So you would have to have a female embryo that is not affected.
Right. Okay.
It would be a headache.
Yeah. Yeah.
But let us know. That's very important. I have never heard of that.
If anybody's interested in doing some research.
Wow.
Yeah.
Wow.
Yeah.
Wow.
Yeah. It's just because you were historically affinite. You historically came together. Yeah. That's a
And-
blessing on one hand, and on the other hand, it's a problem.
And then I just have one more question. So my mom, my sister, and I are all carriers, and we were just reading some research and about carriers having symptoms and possibly leading to malignancies and that kind of thing. How common would that be, do you think?
I don't know the statistics, but there is one family here where this happened, that one carrier was actually presented like a mild Wiskott.
Okay.
And the other female carriers in the same family were normal. And it depends on the inactivation of the X chromosomes, which there's a 50-50% chance average, but it can be 90 to 10% in either favor of the normal or the favor of the abnormal. And if it's in favor of abnormal, then they are presenting like a mild Wiskott. So that's just a statistical problem, statistical event that makes some women using mainly the abnormal X chromosome, and then they can present. And that's in other X-linked diseases also, that it can happen.
Just so you know, I just wanted to let you know we have done a carrier study. So the results are pending, but the initial results did show that 10 to 12% have thrombocytopenia, but malignancy did not seem to be the case. But the results of that, final results of that, will be published in the next 3 months. So we will make sure we get it to you. It's a PIDTC study actually done with the Viscott-Aldrich Foundation. So the study is already done, and we'll have the results to you.
Okay, we have 4 minutes left. I'm going to take one more question.
Hi. You mentioned that you typically at NIH you don't do transplants under 3 years old. Yeah, why? No? Oh, it's not true? Oh, sorry, I misheard.
I'm sorry, it was hard for me to hear.
Sorry.
You said before that at NIH you typically don't transplant
Oh, yes.
after 3 years old.
Yes. Well, that's because, so the NIH, as you know, is a research hospital. It's a 200-bed research hospital, but only about 10 or 20% of the patients who come to the NIH to enroll in a study are children. And, there's a limited number of pediatric subspecialists, and really the hospital is not equipped, to take care of very young children. They are going to start seeing patients down to 2 years, but in terms of interventional studies and transplant, which has a lot of potential complications that need pediatric subspecialists, that's why we don't enroll children less than 3.
Okay, so just on the back of that, would you say what is a good age to be transplanted?
Oh, well, I think that the data would say, particularly for, a full-blown WAS, that it should be younger. I think it's a little bit of a matter of opinion and clinical judgment, and taking into account how bad the platelet problem is, for example. When I was in Boston, I used to try to get people through until, let's say, 6 months or a year, just so that they have more chance for their brains to develop before we subject them to busulfan, because busulfan does cross into the blood-brain barrier, and I thought, if I could, I would rather wait until they're a little bit older. But sometimes there were patients who developed autoimmunity when they were still infants, or had really bad platelet counts, and I didn't want to be facing this question of doing a splenectomy, and so those patients I would transplant sooner. I think different centers have different approaches, and sometimes they'll wait until 18 months, 3 years, but I think a lot of centers would try to go before the age of 5.
In the most recent PIDD study, there are many patients who were transplanted before the age of 1 year. So it's possible, and it's being done. But if you can get somebody a little older, that would be favorable. But there doesn't seem to be statistically some differences in the outcome between less than 1 year and between 1 and 3 or 4 years.